welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Our first presenter is going to be Nick Sandusky. He is from the U of L institution and he is a current PGY2, and he will be presenting on the combined ketamine and midazolam versus midazolam alone for the initial treatment of pediatric generalized convulsive status epilepticus.
So like she said, my name is Nick Sandusky, and today I'll be presenting on the combined ketamine and midazolam versus midazolam alone for the initial treatment of pediatric generalized convulsive status epilepticus. This was a randomized controlled trial, which we will talk a little bit more about moving forward throughout the presentation. All right. So for the objectives, first, recall the mechanism of benzodiazepines and ketamine and the doses that we use in status epilepticus, summarize previous literature evaluating ketamine's use in status epilepticus, and then we'll be looking at the research article that I picked on the utilization of combined ketamine and midazolam, specifically in the pediatric population for convulsive status epilepticus. So a little bit on seizure background. The epidemiology of status epilepticus, these statistics are not specific to the pediatric population, but just overall status epilepticus in general. So it is around 10 to 41 cases per 100,000 persons. And the mortality for patients that do have status epilepticus approaches anywhere from 20 to 60%, depending on a lot of different factors. So it is a disease state that does have a high mortality rate associated with it. Additionally, it is a pretty expensive condition that patients can develop. So the direct inpatient cost is around $4 billion annually. So definitely an area that we want to prevent patients from going into status epilepticus, just from a wellness and well-being standpoint, but also from a financial impact to institutions. So looking a little bit more on the definitions of status epilepticus, the Neurocritical Care Society 2012 guidelines, they defined status epilepticus as 5 minutes or more of continuous clinical and or electrical seizure activity, or recurrent seizure activity without recovery and return to baseline between seizures. There is some controversy around the 5-minute definition, but it's still typically what we see utilized in practice, and one that we'll keep in mind moving forward when we look at what the authors of the study define status epilepticus as. And then there is another definition by the American Epilepsy Society. It came out in 2016, and they define status as 5 to 30 minutes or more of one of the following: so continuous seizure activity or 2 or more sequential seizures without full recovery between seizure events. And they also break it down a little bit more than that. So they have a T1 and a T2. So T1 is when the duration of the seizure is likely to be prolonged. So this is convulsive seizures lasting at least 5 minutes, or unknown focal status epilepticus or absence seizure activity. And they also have the T2, and this is when the seizure duration is likely to cause long-term consequences to patients that fall in this category. And this is convulsive seizures of at least 30 minutes. So there was recent changes to the revised definition when these definitions that we just went over came out. So the reason for, and what, like I said, the 5-minute cutoff is a little bit controversial, but still what we commonly see. So most seizures that occur last less than 5 minutes, and seizures that do last more than 5 minutes often do not spontaneously terminate themselves, whereas seizures that are lasting less than that often will self-terminate. Seizures lasting anywhere from 5 minutes to 20 minutes have increased risk of permanent neurologic damage. And then one of the things that I found most interesting, and we'll talk a little bit more about in the upcoming slide, is seizures that last anywhere from 5 to 30 minutes have an increased risk of pharmacoresistance to the agents in which we do utilize for status. So this is another reason whenever we're advocating for treatment of status epilepticus about why we should be aggressively managing and treating seizures. So looking a little bit more on the pharmacoresistance. So we know that oftentimes pharmacists say, Thomas brain, we need to be aggressive about treating these seizures. And I think this graphic is something that I've used in my practice in the emergency department at kind of hitting the point home to the providers about why we need to be aggressive. So we can see at the milliseconds to second stage, this is whenever we have some of the ion channel opening and closing that occurs, as well as neurotransmitter release, which we do have agents we won't talk about today that do hit on the ion channel opening and closing. And then moving on to our stage 2, which is our seconds to minutes. This is whenever we see a decrease in the GABA activity and an increase in the NMDA receptors in patients that are continuing to seize. So we'll talk a little bit about the study design coming up, but I think this is a really important point to hit. So we have decreasing GABA and increasing NMDA receptors, which is one of the main reasons why the authors of this study chose to look at the regimen that they did. And then looking a little bit more at the morbidity and mortality of status epilepticus. So these statistics are looking specifically at hospital discharge. So for convulsive status epilepticus, the mortality can range anywhere from 9 to 21%. And then looking specifically at the pediatric patients, because this is what population that the article I'll be talking about focuses on, it ranges anywhere from 3 to 11% in retrospective studies. However, in some prospective studies, it's been around 3%. And then looking more specifically at morbidity, so severe neurologic or cognitive sequelae of convulsive status epilepticus is anywhere from 11 to 16%. And then deterioration in their functional status could be anywhere from 23 to 26%. And looking at our refractory status, the mortality for patients that do experience refractory versus the convulsive status epilepticus is higher, so 23 to 61%. And the morbidity in pediatric patients, many of them will have motor and visual deficits that can be seen from refractory status for up to 1 year after refractory status. And then a child that has symptomatic refractory status epilepticus will ever return fully to their baseline. So looking at the general treatment approach that we often see utilized in status. So I'm sure we are all familiar with this graphic and have seen it many times. So this is the proposed treatment algorithm specifically by the American Epilepsy Society. So we can see that our initial first-line treatments are our benzodiazepines, followed by our other options, including phenobarbital, rectal diazepam, and intranasal midazolam. And then moving on to our second therapy. So this is whenever we get into our fosphenytoin, valproic acid, and levetiracetam, as well as phenobarb. And then from there, it's honestly anybody's guess as to what dealer's choice as to what our treatment is when we get to that stage of status epilepticus. So just a quick review of the pharmacokinetics of midazolam. So it is an indirect agonist of GABA A in the postsynaptic neurons, and it will increase the channel opening frequency. So looking more specifically at our dosing, so if we're going to be giving this intramuscularly at 0.2 mg per kilo, or you can do flat dosing of 5 mg per kilo for 13 to 40 kilos, or 10 milligrams for patients weighing greater than 40 kilos. And then for our intranasal dosing is 0.2 mg per kilo per dose, and we split that between the nares for a max of 10 milligrams total. So as we saw earlier in the proposed algorithm, IM and intranasal are the two routes that are suggested. However, in the cases of shortage or institutional practices, we typically will give IV midazolam to pediatric patients. And if we do that, the dose that I've most commonly seen is 0.1 mg per kilo, and we max at 5 milligrams for the IV dose. The onset of midazolam is pretty quick. So for IV and IM is 2 to 5 minutes, and intranasal could be up to 5 minutes. The duration can be a little bit variable, but 20 to 120 minutes. So usually on the shorter side compared to some of our other benzos that we can use. Looking specifically at ketamine. So I know in the ER that I work at, many providers, both on the inpatient side, on patients that are admitted, but also in the ER, everyone's becoming more comfortable with using ketamine for a variety of different things, but both in the pediatric and adult populations. So it is a non-competitive NMDA receptor antagonist that blocks glutamate. Our dosing is a little bit up in the air when it comes to ketamine. So for procedural sedation, dosing is 1 to 2 mg per kilo, and our sedation and analgesia in critically ill patients will be a load of 0.5 to 2 mg per kilo, followed by a continuous infusion. There is limited data on continuous infusion ketamine used specifically in pediatric patients. However, it has been utilized in practice, specifically in the super refractory status patients. It does have a quick onset of action, so around 30 seconds for IV administration, and then for duration can last anywhere from 5 to 10 minutes, but then many patients will have a recovery time and still be experiencing some of the effects of ketamine for up to 2 hours after administration. So taking a look at some previous literature before we talk specifically about the article that I have. So most studies evaluate ketamine continuous infusion versus just giving like an IV push of ketamine. So Chiraboga and colleagues in 2024 did a meta-analysis of 172 pediatric patients. They looked specifically at continuous infusion ketamine and found that in 51% of cases, they had seizure cessation with the addition of the continuous infusion ketamine. Yan and colleagues in 2024 also did a meta-analysis of 11 studies. There was a wide variety of dosing that was utilized in the meta-analysis, further proving that we're not really sure what dose of ketamine is optimal. So anywhere from 0.5 to 2 mg per kilo load, followed by an average of 2 to 4 mg per kilo per hour. And they found high efficacy and safety with the use of ketamine in super refractory status epilepticus across all age groups, and found that the earlier that you administer it, the better that patients did. And then the last study also looked specifically at a retrospective cohorts of 68 patients and found they also did a continuous infusion added to midazolam, and found that the seizure burden decreased at least 50% within 24 hours of patients, and 81% of patients in complete cessation of seizures, and 63% of patients when they added the ketamine to the midazolam continuous infusion they were already receiving. So now looking specifically at the study that I chose for this, the purpose of the study was to evaluate the short-term efficacy of adding ketamine to midazolam as first-line anti-seizure medication for pediatric patients undergoing or experiencing generalized convulsive status epilepticus. It was a randomized 2-group parallel 1-to-1 superiority double-blind placebo-controlled trial. It was conducted at a single pediatric emergency department in Sohag University Hospital, which is located in southern Egypt. It was conducted between March 2023 to April of 2024. And these patients were randomized to receive 1-to-1 ketamine plus midazolam or placebo plus midazolam using random numbers in permuted blocks of 4. These medications were prepared in identical 12 ml syringes. They were prepared by the pharmacy with verification codes that were correlated to the assigned study drug. It was confined, so the outcomes, which we'll talk a little about, was confined to 24 hours from administration of the study drug. And they obtained verbal consent from the caregivers of the patients and then followed up with written consent. And the participants, the parents or caregivers of the children, medical staff, study investigators, and those that were involved in assessing outcomes were unaware of ketamine or placebo assignment. So looking at our inclusion and exclusion criteria, they included patients that presented with generalized convulsive status epilepticus, and they defined this as clinically detectable generalized tonic-clonic convulsions that persisted or reoccurred without complete regaining of consciousness in between for longer than 5 minutes. So a definition that we see clinically used still. Seizure duration was reported by the parents prior to hospital arrival. And they do have a long list of exclusion criteria. So I just highlighted some of the more common ones. There are more that we can talk about if anybody has questions, but it included patients that were treated with any other anti-seizure medication for this specific episode, traumatic brain injury, conditions associated with increased intracerebral pressure, hypertension, alcohol use, hypo or hyperglycemia, known or suspected psychiatric disorders, cessation of seizure within 5 minutes of presentation, inability to obtain IV access within the first 5 minutes, or failure or inability to obtain informed consent. So looking at the dosing regimen that was done for these patients. So initially at the 5 minute mark, if patients continued to seize past the 5 minute stabilization phase, they were randomized to receive ketamine plus midazolam. They used ketamine 2 milligrams per kilo. They maxed at 60 milligrams, and that was an IV push over 2 minutes. In addition to midazolam at 0.2 milligrams per kilo over 2 minutes. And whenever they initially gave the medications in the initial dosing, that was time point 0, which we'll talk a little bit more, but I just want you to keep that in mind when we're going through the outcomes. And so that was the treatment group, and then placebo they received a placebo fluid at 0.4 mLs per kilo. That was an IV push as well, followed by the same dose of midazolam at 0.2 mg per kilo over 2 minutes. The ketamine dose that this study utilized was extrapolated from procedural sedation dosing. So that is where we came up with this 2 milligrams per kilo over 2 minutes. Subsequent dosing, so if patients continue to seize after receiving the initial dosing of the treatment or placebo, they were given another dose of midazolam at 0.2 mg per kilo over 2 minutes. If they continued to seize at 15 minutes, they were loaded with levetiracetam 60 mg per kilo. And at 35 minutes, they were given phenytoin. And then if they continued to seize at 55 minutes, they were then given another dose of midazolam followed by continuous infusion and were admitted to a pediatric ICU level of care. The primary outcome was the proportion of patients who attained cessation of clinical seizure at 5 minutes after administration of study drug. Then secondary outcomes included the need for a repeat midazolam dose in the first 15 minutes, cessation of clinical seizures at 15, 35, and then 55 minutes, seizure control after cessation, so whether patients initially gained seizure control and then had another episode of seizures after they initially stopped seizing, and then a variety of safety endpoints, including hypotension, hypertension, arrhythmia, emergence phenomenon, need for intubation, and a few other ones as well, but those are the main ones that I wanted to call your attention to. So for statistical analysis, the data was analyzed on the intention to treat. Categorical data was analyzed using chi-squared or Fisher exact. They used the Mantel-Hansel method for subgroup analysis. Statistical significance of a 2 to tailed p-value of less than 0.05. And then the sample size was calculated at 58 participants, but then increased to 72 to account for a 20% dropout. So they assessed 251 patients for eligibility. 107 were excluded, and then 72 were randomized to each group. And then since it was a 24-hour cutoff was the end of the study, they did not lose any patients to follow-up, and all patients were included in the analysis. So looking at our baseline characteristics, there were no difference in any of the baseline characteristics between either group. But I did want to call out specifically on the etiology that they did not report on the febrile seizure, whether it was complex or simple, or whether any antipyretic medications were administered on patients that experienced febrile seizure. And then looking at our outcomes, so we can see a statistically significant difference in a lot of the outcomes. So seizure cessation at 5 minutes. More patients in the placebo group did receive a second dose of midazolam, and then greater success of seizure cessation at 15 minutes in the treatment group, as well as at 35 minutes. And then we do see less of a difference, but still statistically significant in seizure cessation at 55 minutes in the treatment group. And then another thing that I wanted to point out was when it came to intubation, that more patients in the placebo group did require intubation. So those patients are going to be buying themselves an ICU stay. And specifically in our pediatric patients can be very traumatic, having to be intubated and admitted to an ICU. And then they did do a breakdown of seizure cessation at 5 minutes after study medication by duration of the seizure before presentation. So we can see that the ketamine and midazolam group still had better risk ratio at achieving seizure cessation. And then at 5 minutes based on etiology, and then again at different age categories. So we can see between all of these that our midazolam and ketamine group did have greater seizure cessation. And then the seizure duration, the very first group was on prior to presentation, which was parent reported. So just something to keep in mind as well. And the authors concluded that add-on ketamine may present extra efficacy over midazolam alone as first-line anti-seizure medications for children with generalized convulsive status epilepticus, particularly status epilepticus that lasts longer than 30 minutes. The 30-minute time frame represents the 30 minutes that patients seized prior to hospital arrival. However, they do highlight that we need to investigate dosing, routes of administration, EEG evaluation of seizure control, and long-term safety outcomes associated with ketamine's use in status epilepticus. So it was a randomized double-blind placebo-controlled trial with baseline characteristics and a clinically utilized definition of status epilepticus. However, they did not utilize EEG confirmation to ensure that patients were having cessation of electrical seizures that can only be seen with the EEG. Specifically in the area where this study was conducted, they do have limited pre-hospital care and prolonged response times compared to the US. And they also don't have a ton of medications that can be administered. So a lot of these patients were seizing without medications, where here in the US, a lot of our EMS crews will give some sort of medication. It is a somewhat small sample size. And then we already talked about the febrile seizure classification and treatment was not reported. So my thoughts, it makes sense based on the slide that we talked about, the pathophys changes that occur in patients that undergo status for ketamine to work whenever our benzos may not be as effective. These patients did present late in their seizure duration and didn't have any medications that were administered, which is often not the case that we see here in the US. There's no well-established dosing that's associated with ketamine's use in status. And then all the patients were received treatment per protocol, which I think is a strength of the study. So you don't have any like deviations in care. Could be difficult until we get updated guidelines on getting prescribers to be more willing to do this up front as compared to saving it for more refractory or later line. And then definitely a strength is the decreased intubation in the study group compared to placebo. So saving these patients a ICU stay. And with that, I'll take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.